Okay, our patient's Mr. Poor, and we have a 63-year-old male who is edentulous and needs a new set of dentures. So what we want to do is to, first of all, diagnose and treatment plan what we're doing with Mr. Poor. Let's see if I can get you up here just a little bit and then down that way, about there. And we want to evaluate what we have in the way of his present dentures and what can we do for him. We do this usually by starting with a diagnosis and treatment planning form that's on the back of the work card that we use in our clinics, and on the back of it is a diagnosis and treatment planning form. And so early in the procedure, what we really want to do is to fill out this form, and we do that by, of course, first of all, getting the pertinent data at the top. Mr. Robert Poor. And your address is 1537 Walter Avenue, and you're 63 years old, male, and your patient number, oh, here it is. Okay. Your telephone number is... Now, Mr. Poor, how long have you worn dentures?
I'd say about 30 years.
30 years, okay. How many sets of dentures you had during that time now?
Three.
3 sets, okay. And when was this last set, the set you're presently wearing, how old are they? How long ago were they made?
I'd say about 20.
About 20 years, okay. Problems with them now?
Not top,
just the lower, okay. Lower only. What type of problems do you find you have with that?
They are kind of loose.
Loose, okay.
Use, easily.
Okay. Okay, now let's get just a little bit, even before I take the old dentures out of your mouth, Mr. Poor, on what you expect from a set of dentures. Now, I know you've been wearing dentures now for 30 years and been three sets of them, and I'm sure you formed some opinions as to what type of things that you would like your dentures to be able to do for you. I mean, I understand that everybody would like them to be just like their natural teeth were, but that's not going to happen. So, just you tell me what things that you would like improved on from your old set.
Well, I'm pretty well satisfied as far as after they once built them up, they wouldn't keep breaking.
Right.
And usually they have to be a little heavier at the top. And that's mostly.
Are you able to eat fairly well with your old dentures? Having any problems eating?
No. Well, I haven't had any problems.
Haven't had any problems. So you expect to be able to eat as well as you do with your old ones. And what about looks?
I don't like for them to look too gaudy.
Okay.
Look more natural.
All right. Let me make a suggestion or so to you as we're getting started with it. That what I see when I look at your face as it is here right now, I can tell that you have an upper denture in there. Not for sure about the lower without ever looking in your mouth, but I know you've got an upper denture in there, and I know that because this lip appears to be collapsed. When I look at that, the red part of your lip doesn't show enough of it. For a woman sitting there, you wouldn't have any place to put lipstick, okay? And that is a dead giveaway as to that there's something false about it. So what we need to do is that over a course of years that you've had 3 sets of dentures, okay, and it's been 20 years since that last set was made, all right? What happens with a denture, an upper denture, as time goes on, as it settles in, it shifts upward and it shifts back in your mouth. That's the nature of the way the resorption pattern goes of that upper ridge, is it will shift up in your mouth and it'll shift back. And the lower will shift down and shift out. So your lower lip will appear too full after a number of years, and the upper lip will appear as though it's not full enough, okay? So one of the objects that we have in making a set of dentures is to build that upper lip back out to where it would be a normal looking, okay, contour to it, and it would show a normal amount of the red part of your lip, okay? All right. And so you want to rebuild the aesthetics, and you want also to function better, okay? Now we're going to take a look at your mouth and let's see what your old dentures look like, Mr. Poor. All right. Okay. Okay, some of the things that we see with your old dentures now that are going to be different. Number one, your old dentures have porcelain teeth in them. And we don't use porcelain teeth anymore, very rarely. I've used maybe 2 sets in the last 20 years, okay? Just about everything that we use these days is what's called hardened plastic, which is, they wear virtually as well as the porcelain, but they don't have some of the disadvantages that porcelain has. Porcelain has the disadvantage that it's awfully easy to break. You get a cherry seed in there and you chomp down on it and the porcelain chips on you. All sorts of things like this will happen to you. And also the porcelain, if you got porcelain teeth in them, it transmits the forces that are generated as you chew with them down to the ridge more than it would if you got plastic teeth in them. And the plastic is a lot kinder to your ridges than the porcelain one. So we want to go to the hardened plastic with it, okay? So we're looking at the old dentures that got porcelain teeth, and they also, the lower has an ezo pad in it, which is your way of relining, trying to stay comfortable until something better can be done. Okay, now we're going to look in the mouth. And what we're going to do is we want to look and see what sort of condition that tissue is, okay, the gums are, that covers the ridges now, to make sure it's nice and healthy before we start making new dentures for you, okay? So just take a look, and basically what we see is pretty healthy looking tissue. It's pretty firm. There's a bit of resorption on this upper because you can see from the level of the ridge here and here to here, and the length of this flange, or this mucobuccal fold area, how far it is from the crest of the ridge up to the mucobuccal fold, that there's been a lot of resorption along this front part of your ridge. So you don't have a lot of ridge left on that upper. It's also pretty flat. See, from here to here across this roof of your mouth, that doesn't have a deep well to it. It's pretty flat. And if you notice, when I rub my finger down the middle of that, there's a hump right down the middle. That's a very small version of what's known as a Taurus palatinus, and that's sort of a natural phenomenon we find in a lot of ridges. And the only thing that a small one like that would do for you is that when you make a denture, you have to be careful not to put pressure on it, because if you put pressure on it, it becomes a teeter-totter, and it'll teeter-totter over that high point right there, and the denture will rock on you, okay? So we have to be very careful in that, not to get pressure on that. Now I want you to put your head down this way just a little bit. Let me get the light this way, and let's look in here and see what we see. We got the same thing. We got an awful lot of bone resorption, and we have some flabby tissue down here on the lower end that this ridge is not supported by an awful lot of bone. It's mostly soft tissue. As we come back to the back, there's a little knife edge ridge sticking up there. Open real wide for me if you can. Okay, we'll look back in here. All pretty normal looking. Okay, pretty normal looking floor of the mouth. It's very interesting that right here, the superior pair of the genial tubercles is right at this level, almost up to the level of the ridge. And so that, usually when you get that, you got a little shelf of bone. Feel that little shelf right there as we come around? We have to be very careful in making dentures that we don't have it resting on that little shelf of bone, or it gets awfully sore on you, okay? So let me write down what we've seen here with this, and then we'll get back to looking some more, okay? Okay, saliva. That's another thing now that can get you in trouble. Now, what holds dentures in place and makes them comfortable for you is a layer of saliva between the plastic of the denture and the gum that's there, the ridges, okay? Now, if that saliva is very, very ropey or thick in nature, okay, it tends to form too heavy of a layer of that saliva between the denture and the gum, okay? And it also tends to be stringy and makes you gag somewhat. So if it's real ropey. Now, we usually expect that when we see patients that are number one. We see alcoholic patients, we see a lot of that in there, and that's what causes a lot of their gagging. We see very obese patients, very fat patients that obviously are very, very overweight. We see a lot of that ropey saliva in those patients because that ropey saliva is caused by eating too many sweets, okay? And the more sugar there is in there, the more of that ropey saliva you're going to see. So what we're ideally looking for now is a saliva, open real wide, that is very, very thin and watery in nature, but an adequate amount of it so that, you know, you always have a real nice moist layer of that thin saliva over your ridges. And that's what we happen to have on yours, is a very thin saliva, or we call that serous, with an adequate amount. Okay, now I want you to just open. Okay, now I purposely didn't tell you as a patient what I was looking for when I had you open, and maybe Dr. Winchy and viewing the monitor back there can see what we're looking for, and maybe she can't, I don't know, but I purposely didn't tell you what I was doing with it because I wanted to see is where your tongue was located. And if you'll notice, your tongue is back and it's held low. Pull your chin down somewhat, this way, there we go. And that tongue is held back and it's held somewhat low, okay? That's a disadvantage, but it's something that you can overcome. So just set your head back there again. The disadvantage that you have of this is patients who habitually hold their tongue back and hold it low, a lot of them will have a tendency to let the edges of their tongue slip underneath the lower edge of the denture, and they try to wear that denture on their tongue, and that's a real problem. So if that is a problem for you, what we're going to have to do is teach you how to keep that tongue up on top, okay? So we call that a class 2 tongue. Already looked at that before when we first looked at you, and we saw that the maxillary is small with lots of anterior, or in the front rather, resorption. Let's see, very resorbed in anterior. And the posterior, that's maxillary now. The mandibular one is small all over and very resorbed. Now, next thing we want to look for is I want to look in your mouth, little attachments of muscles that come in to actually around where the sides of the dentures, or what we would call the flanges or the periphery of the dentures, come in. And those attachments of those muscles generally are little things in the mouth that we call frena, okay? And we want to look and see the size and the shape of the frena and where they're located and where they're attached in your mouth. So the first thing I want you to do is to lean your head back just a little bit, and we're going to look at the upper ones now. There we go. And we see when we look in the mouth on you that your frena are attached fairly far away from the ridge. They're not down close to the ridge. The labial frenum, the one in the front right here, is attached a little closer to the crest of the ridge than the others, but it is not the type of thing that you would advocate having a surgeon place it someplace else. In other words, go in there and move it to another position. Now let's look at the lower ones, and I want you to let your chin come way down this way. That's it, and we're going to look here and see what we see. And again, we have some frena. We can notice some frena here, a buccal frenum on his left, buccal frena on his right, that are fairly heavy but attached fairly far away from the crest of the ridge. So again, it's not something that you would anticipate having to have surgery done on. I see no labial frena. Now put your tip of your tongue right up there for me. Okay. Now the floor of the mouth rises in this area in the lower anterior, what we call the sublingual crescent area, but the frenum is not very prominent. This is a good example of that serous saliva, by the way, and he has lots of saliva, okay? And a very thin, watery type, and that's good, okay? Now let me write down what we've seen on that. All attachments low, except maxillary labial. And that one is high. Taurus, we talked about that before on the maxillary. Let your head drift back a little bit. That's it. And on the maxillary we have a mini torus right in the posterior part of his palate, but it is not of sufficient size or location that it's going to affect us one way or the other, and there are no other tori. Okay, maxillary, small, torus, not significant. Sharp bony areas. We have a knife-edged ridge on the lower, and outside of that we have no sharp bony areas. What we mean by that, just the top edge of the ridge, if you feel all the way around on that lower, the bone on that comes up to a knife edge, okay? Undercuts. No undercuts noted. You wouldn't expect undercuts on a patient who has worn dentures for this long and has had that much resorption, though, because basically most of that alveolar bone is already gone, and that's where the undercuts would occur. Size and shape of the tuberosities is the next question that we need to answer. So I want you to put your head back again, chin up this way. That's it. And the tuberosities is this distal end now of the alveolar ridge on the maxillary just before you get to the hamular notches. And they are very small on Mr. Poor. Forward just a little bit, lower your chin a little. There we go. There we go. And those tuberosities are nice and firm, but they're small. They're small and rounded. Okay? Now, let's note that. Small and rounded. Size and shape of the palate. We've talked about that palate a little bit before, but let's look again now. We see how this palate is virtually flat. It doesn't have a lot of depth to the vault. It's fairly flat across from one side to the other, and it has a raised area or a small torus right down the middle. And that is going to create some problem for us, but not something that we have to worry about. It's size and shape of the palate. It's small, flat, with a small torus. Radiographic findings. We have a panorex of Mr. Poor. I don't think we need to pan onto this, but I want to take one look and see if there's any significant findings. No significant findings of any kind on the panorex. I want to make one comment, though, that may have shown up on this panorex, but it didn't. I read through Mr. Poor's previous dental record here at the University of Louisville, and he was admitted in 1992 to the University Hospital in their Department of Oral and Maxillofacial Surgery, saw you. And you had taken a fall from a ladder, I think it was, and spent a night in the hospital, and they suspected some bone fractures, and the roof of the orbit, I think, is the way they described it. And so they suspected some bone fractures, but they decided to do nothing surgically, and there is no abnormal effects that we see on the radiograph or what we see in the mouth. So it has not had an effect on us, okay? Okay, summary and conclusions. You have what we would call a guarded prognosis of ability to wear dentures, and the reason why is you had so much resorption of ridges up to this point that we're probably going to have to do some special things here and there in order to just make you comfortable with them. One of which I would anticipate on him would be to do a novus liner on him. Right, and I would suspect we will need a permanent or semi-permanent type of resilient type liner. The one that we're most commonly used around here now is one called Novus, and if we have enough base when we finish this thing off and it's thick enough, then what we will plan on doing would be to put a resilient type liner in there to make it much more comfortable for you would than if it were a hard base. And I would anticipate this being probably a pretty good treatment plan is to plan on a resilient liner in that lower. I would suspect that we may have some but not a lot, that we're going to have to take a little special care to get good retention on the upper denture because of the size and the shape of your palate and the way it's flat across there. That creates sometimes some problems in getting good retention on that upper. But if you take care with it and do it well and do everything just as you're supposed to with it, it generally is not a problem. You just can't get sloppy with it. It doesn't work. You have to do your best #1 job with it. Question, retention problems. Now, at this point, I usually find it a great advantage from my standpoint as a dentist, treating you as a patient, to go through some of the things that you might expect out of a set of dentures and to make some comment to sort of start planting seeds in your mind at this point about possible things that you're going to run into. They may be new experiences to you. It may be experiences you've had in the past with dentures but have just forgotten about. But I think it's wise at this point to remind you of things, okay? #1 and foremost, the efficiency of chewing with a set of dentures, when you compare it to natural teeth, is awful, okay? Generally, it is accepted that if you can chew 1/5 as well with a set of dentures as you could with your natural teeth, that's about as good as you'll get. Okay? Other things. A good set of dentures is not made overnight. Okay? It takes about 5 or 6 appointments to get them into your mouth if you're going to do a good job on them. Okay? So you're not going to get them overnight. It's going to take us 5 or 6 appointments with you before they go into your mouth. All right? I suspect because of the amount of ridge resorption that you've had over the years with 3 sets of dentures over 30 years and the last set going 20 years and the EZO pad that you've had in that lower causing some problems with that lower, I would suspect that you're going to have some retention problems. In other words, it's not going to be easy to get them to settle down to where they feel like they stay in place on you. Okay? And I like to tell you these things up front, because if to tell you after it's done and you come in and start complaining about them, to me that becomes an excuse for me not doing a good job, okay? And so we like to talk about that up front and tell you right up front. Now let's talk about aesthetics a little bit. We've already hit on the fact somewhat that we think your upper lip is somewhat collapsed because the upper denture over the years has shifted up in your mouth and it's shifted back in your mouth. And the lower denture shifts down in your mouth and out. So there's 2 things that's going to happen in making a new set of dentures. We're probably going to open up your jaw a little bit. In other words, how far your chin comes up before the teeth touch. We're probably going to open that just a little bit to restore what we call the vertical dimension of occlusion on it, okay, to put it back to where we think it was originally, okay? And the other thing we're going to do is we're going to work with you to rebuild the contour of your lips to where we think that's where the contour of them should be, which probably means that the teeth will be out farther, okay, than what your old dentures are right now. In order to help us with that, what we want you to do is I want you to look around the home, get your wife to look around the home and see if you can find pictures of yourself before you lost your teeth. High school pictures, wedding pictures, what have you, anything that you can find at home that you think might be a help to us, bring it in. And we'll work with that and use that as part of our guide in trying to determine what we want them to look like. The remainder of it, the color of the teeth and the exact placement of teeth, is something that we're going to work with you, and it's going to become a joint decision on our part and your part. And if your wife wishes to participate, that's fine also. Bring her in with you and let her help us determine where to put these teeth and how to arrange them so that they don't end up looking like grandma's dentures, okay? All right. Dr. Winchy, is there anything that I have missed in the way of diagnosis and treatment plan that you can think of?
No. I do not want to go over anything you already looked at the medical history, but the fact that that's reviewed.
Right. Okay. The review of his medical history in the initial screening process indicates that Mr. Poor basically is a very healthy gentleman for 63 years old. We have no adverse diseases that might hinder his ability to wear dentures or the ability of the tissues to tolerate the dentures. So what we're really dealing with is the results of some irritation of old dentures that has caused some resorption and some irritated tissue that we have on the lower, okay? Now, I'm going to ask you to do something that you're not going to like me very much for, okay? I'm going to ask you for the 2 days immediately before the appointment where we make final impressions, I'm going to ask you to leave your lower denture out of your mouth and not wear it at all. Now, you're not going to like that, and I know it, okay? Now, the reason why is that will allow those tissues to heal a bit before we make a final impression on them. Now, the reason why I like for you to do that and to make them as to get it healed is we don't want to build a new denture on irritated tissue. We want to get it in as healthy a condition as we can before we build the new dentures. My opinion when I look in your mouth is that 2 days of that lower denture out of your mouth will do you a world of good as far as getting that tissue healed before we make a final impression on it. Okay?
Okay.